Hi, my name is Dan Partain, and I'm a senior medical resident here at Mayo Clinic in Rochester. I'm here today to talk with you about our new article coming out in the Mayo Clinic Proceedings called Providing Appropriate End-of-Life Care to Religious and Ethnic Minorities. And I'd like to introduce my co-authors and thank them for their support on this paper as well. My first co-author is Dr. Corey Ingram, a fellow of the American Academy of Hospice and Palliative Medicine and a consultant in the Division of Palliative Medicine here at Mayo Clinic. Our senior co-author is Dr. Jacob Strand, who is the chair of the Division of Palliative Medicine here at Mayo. I'm excited to talk about this topic today because it's something that's very important to me personally. I'm planning on doing a fellowship in hospice and palliative medicine next year. The reason I chose this topic is because it's something I think is very important for people in all specialties who take care of diverse patients. Studies have overwhelmingly demonstrated that patients of religious and ethnic minorities have worse health outcomes in a large extent because we have a difficult time understanding their religious and ethnic cultural background and how it differs from our own. They sometimes find it difficult to navigate a health system that does not understand their own cultural beliefs and how that relates to health care. I thought it was really important to bring some of these issues to light and give clinicians an opportunity to learn a framework for discussing these important topics with patients. One of the common pitfalls that we see is called the categorical or cookbook approach. In this approach, clinicians have given a list of things to say or not to say based on a patient's background. So, for example, one might find a list of do's and don'ts for taking care of a Muslim female patient or a Somali male patient. This is a great way to get started, but unfortunately what it misses is that each patient is unique, relates uniquely to their own illness, and may have a large variety of cultural backgrounds. Rather, we suggest an cultural curiosity whereby clinicians maintain a sense of interest and acknowledgement that patients come from unique backgrounds that are often different than their own. We propose a 5-part framework in order to talk to patients about these complex issues. Our 5-part framework is as follows. Number 1, understand the patient's explanatory model of illness. Number 2, understand a patient's religious and spiritual background. Number 3, understand a patient's approach to truth-telling. Number 4 is understand how a patient's family is involved in their care. And number 5, learn to negotiate cultural conflicts when they arise. Patients relate very uniquely to their illnesses, and it may be different from the way you and I understand illness. A nice question to get things started is to say something like, tell me what you understand about your illness. That way, you can have a lot of information right away about a patient's educational background, their approach to how they understand illness, and their approach to how they want to hear about treatment options, testing, and other medical information. Understanding a patient's religious and spiritual background is a strong component of how any patient forms their worldview and is more magnified at the end of life. Karen Steinhauser at Duke has actually validated a 1-question survey which is, are you at peace? And we suggest some variety of this question to understand where a patient is at with their religious or spiritual beliefs and whether or not there are unassessed struggles or problems in their religious or spiritual life. We know that patients overwhelmingly prefer that their physicians ask about their religious and spiritual beliefs and feel better in terms of depression, anxiety, and other psychosocial outcomes when we assess and acknowledge their spiritual beliefs and help patients connect to their religious and spiritual community. In Western medicine, we tend to prioritize the concept of patient autonomy. As part of this, we put a high value on the personal relationship between the physician and the patient, and we tend to think of truth-telling as providing explicit information about medical illness, prognosis, treatments, and so on directly from the clinician to the patient. However, in many cultures, they actually believe that this is harmful and the family should be the one to disseminate sensitive health information because they know the patient the best. Understanding how a patient's family is involved in their illness. I feel that these two concepts are very closely related because in a lot of situations, a family being involved in the patient's care is one of the most difficult cultural barriers to overcome, particularly as it relates to truth-telling. For example, a question we suggest trying is something like, tell me what kinds of information would help you make decisions about your health care and how you would like to receive this information. That way, one can preserve patient autonomy by allowing them to dictate the content and the flow of information. In a world where we take care of patients from a diverse set of cultures and backgrounds, cultural conflicts will come up from time to time. One example of a cultural conflict is a patient that believes that their pain is part of their sense of karma or atonement for previous sins. However, this patient has so much pain that they're unable to have meaningful interactions with their family. A clinician might be able to negotiate this situation by providing a small amount of pain medicine to allow a patient to think clearly enough to spend meaningful time with their family while still allowing them a sense of autonomy to choose to have some degree of suffering that's in line with their religious and spiritual beliefs. We suggest asking questions such as, can you tell me more about your beliefs? Or what types of things are the most important to you in the experience of your illness? These types of questions help bring out what is most important to a patient and allows a clinician an opportunity to discuss these things more fully with the patient and negotiate when there are conflicts. Thank you for spending some time with me today, hearing a little bit about our new article coming out in the Mayo Clinic Proceedings. We hope that this 5-part communication framework allows clinicians to have meaningful end-of-life discussions with patients who are facing serious illness. This 5-part communication model is designed to help clinicians maintain a sense of cultural curiosity and openness and help them understand a patient's goals, preferences, and values near the end of life. I appreciate your time today. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.